Thanks so much, Scott and Rakesh, and thanks for the opportunity to participate in this ICL. I really enjoyed it. A lot of the themes here, these are my disclosures. My biggest disclosure is that about 90% of my practice is deformity, so obviously I'm biased towards the surgical end. So a lot of the themes I think you're going to hear in the last two talks, and I thought they were really excellent talks. I'm going to take more of a literature approach in some of the work that we've done, and to kind of give you my perspective on the task that I was given to speak about, which is adult spinal deformity. This is going to fall in. In an elderly population in particular. So you heard this in Jason's talk. We know that this is a disease that really increases in prevalence based on age, and to the point where it becomes nearly ubiquitous once we get to the 7th, 8th, and 9th decades of life. So certainly we have to be really selective about our indications. It's not like everyone who's above the age of 65 who has a deformity needs surgery. We know that this is a growing problem. By 2050, it's going to more than double this population. And this is reflected in national trends data. You look here, in the first decade of this century, there was almost a 300% increase in what Jason was talking about, T10 to pelvis ASD surgery, as you can see here in this graph, which is certainly a sustainability problem. We're also increasing the complexity of the types of surgeries that we do. We're doing more levels. This is national data from 2 separate databases, more 3-column osteotomies, more interbodies, using higher risk and expensive biologics, and operating on higher risk patients. We know that if you look at, no matter what you look at, if you look at ASLS, ISSG, ESSG, SCOLI risk, about 2/3 of the patients significantly improve with operative surgery relative to non-operative care. But what you don't hear about so much is this almost 20% of patients that do not do well, and if they had the decision again, they would take it back and they wouldn't have their deformity corrected. So certainly there's subpopulations we have to identify that we're over-operating on in this particular population. And a lot of this has to do with, and I agree, the 17% rate of complications would be my dream. A lot of this has to do with the egregious complication rate that we're experiencing. If you look here, this is a series from the ISSG from dedicated spinal deformity surgeons. Their honest 2-year complication rate is 71%. And from a sustainability perspective, increasingly we're being looked at not just in the value of our surgery, but in how much it costs to get to that point. And both of these series, up to 5 years, anyone who had a reoperation did not achieve cost utility based on ICERs at 5 years. And that's going to hurt us in the long run if we want to continue to do these complex surgeries. So the question is with regards to age, is this a high-risk population that we should always avoid high-risk surgery on, or are there different substrates within the elderly population? If you look at our own Mike Dobbs looked at this in the early 2000s, and he found general correlations between complications as well as based on the increasing age of the patient. But if you look at more contemporary literature, you can see that there's some more recent series where you have septuagenarians and octogenarians that seem to do well with surgery. So certainly the temporal age of the patient is not the whole picture, and we have to take a more close look. Some of the work that others have done and our group has focused on is the concept of frailty, where essentially it's not just the age of the patient, but you collectively add factors of comorbidity, social factors, disability, dysfunctionality, and you get a physiologic age as opposed to a chronologic age. This was derived really from the geriatric literature in terms of initially an assessment for proximity to death. And it's really blown up in our adult spinal deformity literature in multiple iterations and categories ranging from cognitive, as you heard earlier, bone mineral density, sarcopenic, functional assessments, and more recently biomarkers and epigenetics, which a lot of us are working on. But arguably the most critical impact it's had so far in the literature is as a risk stratification index. This was the initial version, the Miller Index, which is derived from the general surgery literature, and this certainly correlated with various perioperative outcomes. However, it was very difficult to use because it was 40 items, and you required each one to be present, and it was very highly dependent on patient and PROMs, which is something that it makes it not a true risk indicator. So we tried to alter this, limiting this to the 11 most important factors in our group. And what we found was that, the frail patients, a lot of them actually, and elderly patients benefit most from the surgery because they're so disabled at baseline. But there's this concept of the ceiling effect, where when you reach beyond a certain point of frailty, that risk profile of that patient becomes really too high. And that's really what we've worked on identifying in our research, and others have done the same. So the question becomes, should we be tailoring our realignments based on the frailty of the patient? Contemporaneously, we've learned a lot about alignment as we've been studying age and risk profiles of the patients. I'm not going to belabor the point. You've heard about this before, our understanding of global alignment. But what you don't hear is that even if you achieve perfect global alignment, you have a 30% rate of traumatic mechanical complications. And certainly that's not the whole picture. There's been attempts to have a more specific approach, such as age-adjusted alignment, to kind of come up with a sweet spot between HRQL achievement and minimizing mechanical complications. And as you heard in Jason's talk, the importance of, it's not just the amount of lordosis you have, but it's where it's located, and the proportion matters because you have a fixed amount really between L4 and S1. And the latest concepts are really with regards to segmental alignment. Where do we place the apex of our lumbar lordosis, and where do we place our inflection point? But I would say my first point in terms of treating the adult population is a lot of these patients, this isn't your first attempt at them. And this is a patient that referred to me. They had 4 previous surgeries, and increasingly what they did was they locked in a malalignment, a patient with a high pelvic incidence. So a lot of these cases are really increasingly iatrogenic. So this patient needs a major realignment as they present themselves as a deformity at the age of 74, when these problems really could have been addressed in earlier decades. So how do we incorporate frailty into our realignment schemes? So we've tried to tailor our age-adjusted alignment goals to physiologic age and not just chronologic age, but that's not the whole picture. So it's not just the amount of frailty that you have in your realignment goals. If you have large deformities, you need large corrections. So the invasiveness of the surgery really matters as well. I looked at my patients, and we divided patients into high frailty and low frailty, and high deformity severity and low deformity severity. And we wanted to see which ones achieved really an ideal outcome. And we found, to the points made in the previous talk, if you lower the invasiveness in the high, frail, severe patients by about 10 to 20 points, you can really minimize their risk profile. So, the idea of doing less, and we'll talk about that in subsequent sessions. So this is kind of an early case, early in my practice about 10 years ago, where I really wanted 83-year-old, presented as a deformity, had previous surgery elsewhere, and I really wanted to make the x-ray look perfect, and I really did too much here. I did an osteotomy, a 3-column osteotomy. I fused the entire spine when I could have done a lot less. And this patient ultimately did okay, but they really had a rough postoperative course. And I would argue that type of surgery with a 3-week stay, multiple medical complications, is not sustainable. You've heard it before. We also have 74-year-old patients who play pickleball and golf, who can tolerate these surgeries perfectly fine, such as this patient went home on post-op day 2, went back to Buffalo. And this patient with a hemivertebra resection at the age of 65 for a fixed coronal deformity, where they tolerated all posterior resection and a combined AP approach. So, certainly these are different types of patients. So I would be remiss if I didn't talk about optimization. You heard it earlier by Scott's talk. That was really excellent. Just a few points. We all know the importance of this in this population. You cannot operate on these patients. You see them on 1 week and operate on them the next week. It's really a 3 to 6 month process to get them into the level of substrate where they can tolerate these patients. This is a nice systematic review going over all the points that we can optimize prior to surgery. And I looked at my series, and we looked at just optimizing diabetes and osteoporosis, and we found that you could really minimize the cost, and you can also minimize the healthcare resource utilization, and obviously improve the perioperative outcomes. Increasingly, we're seeing the role of MIS on these particular cases in order to decrease exposure-related morbidity. This is a case I stole from Paul from our research study group, and we'll go over it a little bit. But essentially, our initial attempts with MIS really had the issue of not appreciating the sagittal correction, just going after the coronal correction. So oftentimes we get really bigger problems, such as this case in the literature where they created a flat back here, and then this recent consult that I have here where they're creating really upside down spines with new expandable technology. It's tough to see which way is up and which way is down there. We've certainly made improvements, and we have more tools in this armamentarium for MRS deformity, whether it's evolution of technique with anterior column releases or new technology, robotic-assisted surgery. Some of the pros include that we have better fixation with robotics, and we can really put screws in from any position. But some of the cons are really, the literature hasn't borne out a pure benefit, and at what expense? From a radiation exposure, from a capital expenditure exposure, and also from operative duration exposure. And the literature is really equivocal on whether or not MIS or open really makes a difference so far in adult spinal population. But I would say we're really comparing apples and oranges because we don't treat the severe deformities yet, except for very few centers with MIS techniques. And this was Paul's case, the Jehovah's Witness, that a lot of us could do with single position techniques now, minimize blood loss. And Paul did this with a very nice result and was able to avoid blood transfusion. Patient had a really nice recovery. Just some final tips before I wrap up. It's very important in John's talk, you don't treat the deformity if that's not symptomatic and if they're well balanced. Selective fusions and fractional curve corrections do very well in patients that are very well balanced, and that's their primary pain generator. And really, you have to avoid three-column osteotomies in elderly, frail patients. It's a setup for disaster, and you really need a good reason to do these in these patients because they're not going to do well, and they're going to have a really prolonged outcome. These are two recent patients of mine. This patient had a terrible LDI, 72-year-old, but I didn't think it was worth it to do a three-column osteotomy on him, and just with simple fixation, I think we got a very nice outcome. He was a laborer. He was still working at 65, and he's back to work. And this is a previous patient of mine. I revised her Chiari, and she had a collapsing thoracolumbar scoliosis. She really couldn't stand for more than a few minutes. And she required, to the point earlier, she required a really extensive reconstruction, but it was all done posterior. We avoided a VCR on her with posterior column releases. There's a lot of concepts presented here. How do we put them all together? Well, in the future, maybe AI will help us put them together, but it's difficult during a spine clinic to do all these measurements and all these risk assessments. But I think it's critical in these high-risk patients. So ultimately, know your patient and have an alignment and invasive goals tailored to the specific needs of your patient. Thank you so much.